Just a few reminders. The first being never undervalue the complexity of patient care based on the frequency in which you see that diagnosis. What I mean by this is if you are a provider who frequently sees patients for pyelonephritis, please do not consider them a low complexity or a low risk patient just because of how comfortable you are with this patient type and this plan of care. Additionally, medical decision making, the complexity relates to the number of diagnoses and/or treatment options, as well as the amount or complexity of data and the risks of complications. You may find yourself using time as your support for your billing codes now. However, there may be times when you see a patient in a shorter amount of time than a level 5 visit would support. However, if you are doing something such as titrating lithium or amiodarone, you will still qualify for a higher level of visit even though you don't meet the time criteria. So please keep in mind the complexity of medical decision making you are using, even if you are not using the amount of time required to use time to support your billing codes. Also, remember templated notes not only save you time, but they serve as a reminder for the required documentation um, to support the CPT code, as well as the ICD-10 code that you're selecting for the patient. Templated notes tend to be easier for the provider to toggle through and fill out what they need to. However, be mindful of template fatigue. That is easy to tab through very quickly and forget to edit any pertinent positives or negatives for the patient. So just keep in mind your templates you may need to be aware of what's in your template and what you should and shouldn't have already pre-filled for that patient. And then lastly, management of an established problem has less risk associated than a newer problem, and a worsening condition carries more risk than a stable condition. So when you're considering how complex the medical decision making is, all of those are important pointers to keep in mind. And a few more coding reminders for you. The first being specificity. Whenever possible, avoid ICD-10 codes unspecified. There are going to be times when you have to choose abdominal pain unspecified, and that's okay. But oftentimes we can narrow down our ICD-10 codes to be more specific for a diagnosis. So when you can, do so. Account for your time. When you are documenting how much time you used for the patient encounter, as well as reviewing the patient's history or diagnostics, specifically state what time you used to do so. That means if you say 45 minutes was used to review the patient's chart and for the encounter, that is not as specific as saying 5 minutes was used to review patient's H&H, history of ferritin levels, and 40 minutes was used for the patient encounter, etc. Document it. We've all heard the saying, if it isn't documented, it wasn't done. Accurate, thorough documentation that supports each discussion point covered in the encounter, as well as any necessary diagnostics, exams, and procedures that were performed, will result in less claim rejections and audits of charts down the road. And lastly, linking symptoms to the cause. Whenever it's possible, document the symptoms that the patient is experiencing to the cause. So if the patient is experiencing pelvic pain due to pelvic inflammatory disease, document that rather than just saying pelvic pain or sepsis due to community-acquired pneumonia.